University, and I'm here on behalf of the German Center for Infection Research. As the name of the center says, obviously there was a lot of refocusing in the COVID pandemic, and there's still a lot of ongoing post-COVID research, and we have three interesting and exciting talks given the time frame. I'm not going to take any time away from Maria. The title is already here, so I won't read it. Maria Vehreschild, not very far off. She can walk over here from Frankfurt University Hospital. Looking forward to your presentation.
Yes, so this is quite a special day for trials in post-COVID syndrome. You will see why in a couple of minutes. And my task is to explain the challenges to you that come up when you do such a trial. So in short, we have a lot of challenges when we talk about post-COVID syndrome. I think most of you are aware of this. We have high numbers of patients who fulfill the WHO definition, but that doesn't mean necessarily we are totally sure they have post-COVID because the pathophysiology is not fully understood, and we don't have validated biomarkers for its diagnosis. So mainly due to that, we also have no curative treatments so far that are based on scientific evidence, and evidence keeps on emerging very dynamically and has to be integrated into the clinical trials that we are trying to put together. So normally a clinical trial is something that needs a lot of time for planning, a lot of money, and it's extremely rigid. You can't change a lot once you have submitted it to the authorities. That's how it's going to be. And so what we established to change this a bit and to take the emerging evidence into account is a clinical platform trial that adapts to the emerging evidence. What does that mean? It means I have a concept where I can include new sub-protocols to include new drugs that are emerging, and I can also change the randomization ratio of the different arms in my protocol after interim analyses if I see that a certain arm seems to be more successful than another arm. This is the short overview on how this works, but you can already see it's a bit more complex than a normal trial. And at the moment, we are running the Rapid Revive sub-protocol as one sub-protocol attached to our master adaptive platform trial protocol. And we have submitted an application for the second sub-protocol, which will be called ELAPS. And all of this is within the Netzwerk Universitätsmedizin, and here below you can see all the different entities that are contributing to it. This is an immensely complex trial, and you will further see why. So the main objectives are for all the sub-protocols. We want to assess the impact of different durations of antiviral PCS treatment or any other PCS treatment on the overall physical function, and we want to identify biomarkers that will help us to identify patients early that will respond to medical treatment. And in the first protocol, we tried to take the current state of evidence into account, and you are all aware of the fact that there are different pathophysiological hypotheses that are currently supported, and all these different hypotheses have one thing in common: they cause inflammation or they maintain inflammation. So if you can somehow target inflammation, we thought that would be a good thing in this kind of trial. So for different reasons, I stumbled over this drug here, vidofludimus calcium. I had already been PI in a study for acute COVID infection, and there this drug was used, and we had some preliminary data on it, so I was aware of it, and then I understood that it was not only active against SARS-CoV-2 but also against a broad range of other viruses, because it's not a very specific drug. It blocks the viral replication per se. It's from the class of the dehydroorotate dehydrogenase inhibitors, and It also acts with the pyrimidine use of the cells, and that is also how the viral replication is inhibited. It also inhibits lymphocyte activation and cytokine release by that way, and that way it also has a broad anti-inflammatory activity. It's also currently used in a study against multiple sclerosis, and there, in the interim analysis, some nice effects are seen. And this kind of fits because, as you know, multiple sclerosis is also an inflammation-based disease. So the first sub-protocol is very simple, 2 arms, randomized, placebo-controlled. Patients are treated for 56 days with a drug and then followed up until day 84, and the physical function is assessed at day 56 for the primary endpoint. Now, what are the challenges? The challenges are exactly what I already presented. There are many hypotheses why people could develop post-COVID. So we are suspecting that really there are different types of post-COVID syndrome, and we are trying to address all these different types with one intervention. And maybe that is not really very realistic, but that's the thing we could do at the time we were planning this trial. And we need to be more differentiated in the future, probably. I hope that from this trial we can learn something that helps us to be that differentiated and pick those patients who will specifically profit. And the same is, of course, true for the endpoint. If I don't really know what the mechanism is and which are the best patients, it's extremely hard to define a good endpoint. Another thing, not very biological, more bureaucratic, contracting times for clinical trials in Germany are quite long compared to other countries. This analysis is not very new, but I'm afraid it hasn't changed much yet. So we have the longest times for setting up contracts for clinical trials. And if you look at the data structure of this adaptive platform trial, I'm not going to explain it to you, but I would think that you agree that it is not entirely simple. And based on this data structure, we have this contract structure. And you can imagine with all these university hospitals, companies involved, it did take a bit of time to establish the framework and then all the subcontracts. So that really cost us a lot of time in the beginning. But once all of these were signed and everything was ready, the recruitment went really well. So the blue curve is what we extrapolated should be happening, and the green curve is what really happened. And you can see that especially in this year, people really caught up to what they were supposed to do. And today we have 149 patients. Maybe in this moment we can include the 150th patients. We don't know. So we will soon have the first interim analysis results. So that also shows us, I mean, this curve that I showed before, this is quite unusual. If you're doing clinical trials, normally your curves are like this, and you're kind of sad because you expected something else. So it's not very common that you have more patients who actually fit the slots that you can offer than you have staff to take care of these patients. So we were really overwhelmed with suitable candidates. In Frankfurt alone, we had over 400 requests from patients who wanted to participate in the trial. And we don't really have resources to talk to all of them. And this is problematic because you want to have a good institution-patient relationship, and you don't want to not respond to all these calls for help. So we put up a website, we put up emails, every site was mentioned on the website, people could see when they would fit in the study or not, so we tried to give out as much information as possible, but maybe in the future something like a like a patient registry would be helpful that can then be used when a new trial comes up to pre-sort the people that could fit into this trial, because then we can focus more on actually carrying out the trial than trying to talk to interested patients. Another challenge were the sensory devices. We included 2 types of sensory devices because previous studies have shown that this very granular data can help to identify post-COVID syndrome. And we also had questionnaires for patient-reported outcome measures in an app, but it was not as easy as we had thought. So even though all these devices were CE certified, we realized that it's something else when you want to contribute something to a clinical trial that is placebo-controlled and randomized, and that most companies are not aware that this is an entirely different challenge than just putting out a CE-marked device that is much easier. So we had to discuss a lot how the blinding can be maintained when there is a technical problem and so on. So the first uses were a bit difficult, connections didn't work all the time, and in the end I felt that we were paying a very high price for something that worked only moderately well. So next time I would be extremely careful when picking these companies and really check whether they have some previous experience with clinical trials. So in summary, to not overextend my time, we were successful in implementing the first adaptive platform trial for post-COVID syndrome in Germany in the context of the network University Medicine. We could start and are now successfully completing the first sub-protocol. We requested funding for a continuance with a second sub-protocol that will focus more on fatigue syndromes, and we encountered a series of challenges that I think some of the information we will get from this trial will help to resolve, but that we really have to take into account more when we set up the next sub-protocol. But I think especially for the data safety and the contracting, we now have everything in place, so this will be much faster next time because we can use the same framework. And and also about the patient management, I think we now have learned how to better approach this. This is all from me at this point. I'm very happy to take your questions. And also I wanted to thank all the involved sites and the ZKS Göttingen, which are supporting the quality management of the trial, and all the laboratories, well, all these many people who have made this possible.
Thank you so much, Maria, for giving us an overview of the challenges and how you managed to slowly overcome them with some improvement. Questions from the audience? Just come up. Otherwise, I would have bridged it, but go ahead.
Thank you for this nice presentation, and I think it's a great success, so congratulations from my side. You just speculated on this register for patients. I think this is a very great idea. Could you speculate a little bit where this could be connected to, because you need an ethical vote for that and so on. So have you some ideas in mind which you could share with us?
Yeah, I do have an idea, but I haven't asked the responsible persons. Maybe a bit unfair. So I know that Oliver Corneli in Cologne, he runs not a patient registry, but a volunteer registry that was initially intended for vaccination trials. But when I thought about it, we would actually need something like that, but with patients, and they could enter their post-COVID syndrome symptoms, and then as investigators we would be able to kind of pre-filter these people and then contact them. I think the main obstacle is probably data protection questions, but I would think that if people consent in a written form to being recontacted and contributing this data, it should probably work.
Yeah, thank you.
Good.
Hi, yeah, thank you very much. I was wondering, with these second sub-protocols, are these different versions of the protocol you already have with the same drug, or does this concern new drugs that will be tested?
Mm-hmm. That's going to be a new drug, but you could also change something in the protocol that is ongoing. Like in theory, both is possible.
And do you think you will be able to, if you say you keep the same infrastructure, does this mean that you will also keep the same patients, or will it be just easier for you to recruit new patients?
Oh, that's a good question. In theory, the same patients could participate again if they are not feeling better, which I would regret. But I think also new patients would come in. It's not necessary to take the same people. It's more about using the same infrastructure and the same sites again, because they now have a routine in performing these trials.
Thanks very much. I think in the interest of time, we would continue. Thank you, Maria. With all the difficulties and challenges of defining post-COVID and pathophysiology, I think most people would agree, or everybody would agree, that immunological aspects do play a role in this and probably play an important role. So we're very happy to have Christine Falk from Hannover here today to talk about immunological aspects of long COVID, depending on initial infection severity before vaccination.
Yes, exactly. So thank you very much for the invitation, and we did this together with the outpatient unit that Tobias Welte started very early in 2020, and I would like to dedicate this talk to Tobias Welte. And Isabel Pink and Nora Drick were the two clinicians who really started the outpatient unit at MHH. The reason I'm in the DZIF session is that we started this project with the DZIF funding and also COFONI and NUM, and this was also the starting point to become a member of DZL, which is really wonderful because we're also working in the lung. I would just want to emphasize that the patients defined that there is a long COVID kind of problem and disease, and there are the different phases that we are all aware of. But I would like to emphasize here that the study that we did started really before the vaccination came along, and I think it does just make a difference whether the patients had been exposed to the virus before Omicron and before vaccination. So everything I'm talking about today is about patients who were in the first phase, pre-Omicron and pre-vaccination, and this is something I think it should be considered for the different kind of studies. You all are aware this entire day on the difficulty to define the symptoms, and our clinicians have really done a great job, and I'll show you later on how they try to clinically catch the momentum of long or post-COVID. I would like to talk briefly about the initial severity, which might have a difference immunologically. I would like to then refer on what you've heard today also before, that there's a sustained immune dysregulation, and on autoantibodies that Herbert Schiller was also referring to, just to give you an idea how we try to identify how the immune system is dysregulated in these patients. I just would like to highlight two recent papers. This is from Kiko Iwasaki. What's nice here is that she showed again that there is a dysregulation in lymphoid and myeloid compartments, that there are not only high antibodies against SARS-CoV-2, but also other viruses. And I think it's important to mention that many of the post-COVID patients experience reactivation of persistent herpes viruses, and that might be sort of a combinatorial effect. And this is also something that she has seen there, and this is also something that a recent study from Fasin Mashregi from Andreas Radbruch's Institute has seen in children with MIS-C, so the multisystem inflammatory syndrome, because they have seen that TGF-beta is one of the key cytokines that we missed, by the way, to measure. But the important thing is that they propose that in these children, the reason why there is an EBV reactivation is simultaneously the effect of TGF-beta suppressing T cells, and at the same time to provoke viral reactivation. And I think we should really consider that SARS-CoV-2 is not alone. Persistent viruses really might have a strong impact on what's happening there. So in our cohorts, we started together with Tobias Welte in the outpatient unit to discriminate between patients with long COVID symptoms who had been hospitalized before and at ICU and the mild cases. We also had a transplant cohort and a cancer cohort and a vaccine cohort just to compare the different cohorts. What I'm telling you today is a bit of a glimpse of what we are looking at with these all cohorts of long post-COVID syndromes. Non-hospitalized were the mild cases, hospitalized and the formerly severe ICU patients. And you see here already BMI and other parameters have been different already, so that the patient groups might really differ depending on the original disease, and this is what I would like to highlight here. This is the overview of the outpatient unit with Isabel Pink and Nora Drick, and Tobias Welte really had a strong impact on how this is designed in terms of the evaluation of the clinical status plus the fatigue score, the LRS score, which is then also available in concordance with our blood samples. And we started 6 to 8 weeks ago after the acute infection, which was determined by PCR positivity, and then the 9-12 months follow-up for these patients. So this was again the very early phase, which gave us the chance to really look at them for quite some time, at least 1 year. So I mentioned, and I will just briefly go into this, that there are differences in these three groups. And we realized that there seems to be a dysregulation at the T cell level that has been published also with other groups, so that the naive or the mild cases had more naive T cells compared to the others, which shifts the T cell repertoire towards a memory compartment. And if you look at this graph here, especially the T cell, but also other, especially the myeloid compartments as well, discriminate in immune patterns that are really distinct between these patients, and they are like enriched with the mild cases here seen in gray and orange, and those cases that were more severe, and the formerly ICU patients that you see down in red and here in blue and green. So what we really see is that there is an impact. It's compared to healthy individuals pre-pandemic, and there is a sustained dysregulation at the cellular level. Just briefly to go into more detail, we were focusing here for this talk on the formerly ICU individuals because we had a chance to monitor them and to include the clinical parameters of their long COVID outpatient unit, like lung function, the 6-minute walk test, and the fatigue score, to see whether we find any ideas whether immune parameters would correlate with that. If you look at the unexposed, this is our little cohort, pre-pandemic, non-vaccinated, so zero contact to the virus or vaccination before, and the ICU phase, which was the acute phase, and then those patients, we call them re-ICU, and you see here already that the immune phenotypes are different, and especially the plasma proteins, which is primarily cytokines and chemokines, and I'll show you in a minute what these factors are, but here we correlated them to the lung function as well as to the LAS score. And what you see here is that there are some chemokines and also metabolic or cardiac markers that seem to correlate rather with the lung function. What we did not find from all of these more than 500 individual markers, we did not find one that did correlate with the LRS score, which at least gives me sort of one of the explanations why it might be difficult to correlate immune phenotypes with the fatigue score. What are the immune phenotypes at the cells? Well, we have here an enrichment, and in the long post-COVID cohort of those patients who had been in ICU before, have less naive T cells, so the T cell receptor repertoire or the T cell repertoire is not recovering, and then enrichment of terminally differentiated CD8 T cells. We see that also with the acquisition of the sort of late memory marker CD57, so that we really seem to have here a T cell memory-driven phenotype, and with the B cells, I don't show you all of these raw data, it's opposite, they are more naive B cells. So this seems to be a dysregulation in terms of a memory-driven T cell versus a more naive B cell compartment. These are the soluble factors. We looked at more than 100 of those. You see again that the PCA nicely and also the unsupervised clustering separates them. And what do we see here? We do have sustained like chronic inflammation that many of you have seen also in your cohorts, driven by cytokines and chemokines. But in addition, and this is what we have published for the ICU patients in the first phase, they also had a endothelial dysregulation and endothelial injury, and this is something that adds on onto the immune profiles. And so we have a sustained pro-inflammatory and also an endothelial injury pattern in these patients that holds on for 9 months at least. So it's really hard to recover, obviously, after intensive care unit stay of COVID. We looked also at autoantibodies, but on a targeted approach. So we wanted to look at autoantibodies against cytokines and nuclear antigens like DNA or nuclear proteins or cytoplasmic proteins. We are missing good targeted assays for the GPCR receptors, which I would love to do because I truly think we should have a look at those. But at least if someone has a good assay, please let me know. And then we wanted to know whether there's any hint of cross-reactivity, and that's what I'm going to show you today. So in these formerly ICU patients, we find that 25% of them have anticentromeric protein autoantibodies and again other antibodies, including anti-IL-1 alpha and anti-BAFF antibodies. And here in blue, you see those patients at their time at intensive care unit. And you see here in purple and pink that there is a follow-up time. And you see that these autoantibodies were there already at ICU and they did not disappear with very few exceptions, meaning that we have no clue whether the autoantibodies have been before they acquired severe COVID, but they were there and then they were obviously not disappearing by themselves. Did they correlate to the lung function? And at least there are some that seems to like the centromeric protein autoantibodies. The numbers are small, we know the limitations are really strong here, but at least we have an idea that this might be the case, that some autoantibodies are associated with lung function, but again, not with the LRS score. So we did find, and we have control cohorts of course, we did find some subgroups of patients with autoantibodies. And then we wanted to know whether they could be cross-reactive. So this is a subset of patients where we decided to look at that. We have here the patients, and you see here those, and these are the numbers. We tested 40 as a subgroup. At the moment, we are completing the entire group. So 40 patients, and then you see the numbers here of those who have autoantibodies if you test them directly. And then we developed an assay where we just catch the spike and N autoantibodies in the first place and then run the autoantibody assay again, meaning that if they would be cross-reactive, the levels of the autoantibodies should go down because they were captured by the spike or the N protein. And what you see here in this example of proteinase 3 autoantibodies, you see that for 10 of 11 patients, these autoantibodies really go down and only one stays the same. And to me, this is the first idea that we created, that there might be cross-reactive autoantibodies that recognize both spike or N and the autoantigen, which gives probably a link between those targeted autoantibodies. And then we had a control cohort, of course, where we were looking at pre-pandemic individuals, and we had only a few with these autoantibodies. And here you see in this example, there are some individuals who do have cross-reactive autoantibodies. And this is the idea that probably there are individuals before the pandemic who had autoantibodies in the first place, and by chance they'd also recognized spike or N. And if so, this would then provoke the sort of autoantigen-driven expansion if you get infected and or vaccinated, because this would be like a second activation of these autoantibodies. So I think we should really try to investigate that. I won't go into detail, but in our hospital there were 3 post-COVID individuals who were sort of trying to figure out what's going on here, and we identified that 2 of them had an infection by N antibodies. But again, with these patients, you see that very nicely here, the autoantibodies are cross-reactive with spike and or N, and you can nicely see that some of these autoantibodies actually are going down after the capture assay. So again, this is very small groups, but there might be a hint that some individuals have cross-reactive autoantibodies. And Maria has nicely shown this figure, which I really like. The reference was just missing by Davis in Nature Microbiology 2023. I really like it because it shows there might be subgroups, and this is sort of my basic message. I'm not sure about the persistence of the virus. It might be, but I would say it's rather rare, but the dysregulation of the immune response is something that many of us have seen. I know that Anna Aschenbrenner was also referring to that. There might be viral reactivation, and I think this is something we should really take into account, that other viruses might come into play. Autoantibodies is something I would love to see subgroups of patients according to their autoantibodies, and again, the neuronal autoantibodies against GPCR are top on my priority list because they would fit to a lot of symptoms, including vascular, endothelial, and also energy deficit symptoms and the neurological dysfunction. And with that, this was just a tour de force through our little approach to try to understand long post-COVID. This is my wonderful PhD student, Luisa Ruhl, who did most of the work. I would like to dedicate and remind again to Tobias Welte, and here's Marius Hüper, Isabel Pink, and Nora Drick. And with that, I'd like to thank you for your attention, and I'm happy to take questions as far as my voice is holding that. Thank you so much.
We won't keep it too long, Christine, so the voice will make it. We won't keep you up for another hour, so it should be okay.
That's good.
Go ahead, Susanne.
Thank you. This was really impressive. My question is about the T memory cells that you see in this re-ICU admitted patient group. So did you check whether the memory function is correlated with readmission, or is there any function on this like memory phenotype, or is that just on quantitative level?
So we try to combine that with IGRA assays, so interferon gamma release assays against spike. And there's no direct correlation, which is not surprising. I would not propose that these are the specific ones only, but it just tells us there's also lymphopenic events. So it's not only an increase, these were the proportions. We have the raw cell numbers. So there is still some kind of lymphopenia, and then rather an enrichment of the late memory cells and a disappearance of the naive ones, where we have no idea where they're going and why they're not coming back. So I think we really always need cell numbers, because otherwise you would argue for an increase, which is actually just they stay and the others disappear. Yeah.
Thank you.
Good.
Excellent talk. I have a question relating to the beginning of your talk. If there is virus reactivation, chronic reactivation, would you speculate, should one derive any clinical action consequences from that?
This is something where I would refer that to the clinicians. It's an observation that many of the long post-COVID individuals have herpes virus, HSV, EBV, sometimes CMV, and sometimes all of them. And you see IgM, which is the hallmark for reactivation. I'm not sure whether I would go into a clinical setting. I would ask Susanne or the clinicians in the room, but it's just something where you could have an added impact on other viruses that might contribute to the symptoms. And if you just focus on SARS-CoV-2, you may not really hit the causative agent. And I would not go more far into detail, because I would love to see that there would be probably studies needed, but I would at least consider that.
Klaus Michael, last question.
Christina, thank you. Short question. In contrast to the adults, children, and we know from our study and that of others, produce a stronger B-cell response with more sustained antibodies, yet the autoantibody phenomena are less prominent.
Yeah, and you know what I think, Klaus Michael? My hypothesis, which I cannot prove, that it's all related to the repertoire. That you have a broad, naive repertoire in children that gives a strong response, but it also keeps the balance. And there are work from Fritz Melchers and Harald von Böhmer that there's a feedback loop on autoantibodies. And my hypothesis is it works better in children with their broad repertoire. And the older you get, you have not the naive repertoire, you rely on your old repertoire. And then these are probably more sort of, they have a history, and that makes them more clinically relevant. But this is just an hypothesis. I don't know whether that's true.
Thanks so much, Christine, again, and best wishes for your voice.
Ja, danke.
We continue with immunological aspects and have a third very exciting presentation from Clara Lehmann from the University Hospital in Cologne, and move from the periphery into the tissue resident compartment.
Yes, thank you. So I'm happy to be here, and really I'm impressed today, all the talks. I think it's a great meeting, and we should really continue in this direction. As already mentioned, there are different mechanisms discussed, and possible mechanisms include autoimmunity, we already heard about it, inflammation, of course, a lot, reactivation of EBV, permanent organ damage, but also viral persistence in tissue reservoir. I think all the different mechanisms are not exclusive, but maybe they are also complementary. And we have to see how we can understand this. And I would like to continue on the topic of the viral persistence. So it is not a new phenomenon. We know from other RNA viruses that there is persistence after acute illness. Especially there have been some RNA identified in different tissues months and also years after infections. For example, for Ebola virus, we know that there have been new outbreaks with carriers, persistent carriers of Ebola virus. But also for the Zika virus, we know that there are some transmissions, sexual transmissions of Zika virus after months of recovery. So this is something which is not new, and there have been several publications about the persistence of SARS-CoV-2 in different body tissues. For example, in autopsy biopsies or tissue biopsies, RNA but also protein has been detected in different reservoir sites. And this is a very nice review which has already been published in 2023 with different tissues, but especially there are 3 publications in the gut in the gut tissues. And so I think what we have to discuss, which role this persistence could have, and how the reservoirs, the potential reservoirs, could contribute to the post-COVID symptomatic. For example, here, this could be one thing that we have a constant immune activation. This is what we have also discussed today with differentiation of T and B cells, but also genetic and epigenetic changes, and also dysregulation of the microbiome. Now I would like to present one project which has been supported by the BMBF. It's Too Long for COVID. And so we have different work packages in patients with long COVID. So we have one part just in the peripheral blood, and then also third part is epigenetic analysis. And the work package I would like to show today is the analysis on the viral reservoir and local immune responses. So why do we look to the gut, and especially to the terminal ileum? I have here a nice figure, I think, where you see the total gut. It's really long, it's several meters long, and different parts, and you see duodenum, jejunum, ileum, and the colon. And what you can see that the terminal ileum, we have the Peyer's patches, and this is the part where we really have, this is the largest lymphatic organ, and this is why it's really important to analyze this part. But you can imagine it's kind of difficult to reach this part. And I started to work on the gut-associated lymphoid tissue in the field of HIV. And when we talked to our ethical committee, they said, well, you can't do it. It's just too difficult for the patients to do a colonoscopy. And they asked us to do a mapping of the gut to see where we could have the most of the cells in different gut sites. Because they said, well, maybe you could just go to the rectum or the colon. And then this is what we did. It took several months, and then we went back and just showed the data that, well, the terminal ileum is a place where we have to look because this is where we have most of the cells. And so they accepted this, and this is why we always focus on the terminal ileum. So the study design is a cross-sectional controlled studies in patients with post-COVID syndrome and also in patients without post-COVID syndrome. They all needed to have a confirmed SARS-CoV-2 infections at least 3 months prior to study enrollment, and the patients the definition of the post-COVID syndrome was like the WHO definition. So we identified the patients. They were undergoing a colonoscopy until the terminal ileum. We collected samples, and then we just did the incubation of the tissues and collected the supernatant, etc. And at the same time, we also had peripheral blood of these patients. Then next day, we did a density gradient centrifugation, and we have an LPNC layer, so we could do a downstream analysis, flow cytometry, but also immunohistochemistry of all these samples. So our study populations, we had 20 patients with post-COVID syndrome and 23 controls. They were between 22 months post-infection and 15 months post-infection, the post-COVID negative group. Mainly female as usual, and they were around 45 years old. All the patients during the acute phase were just in the outpatient clinic, so nobody was on an intensive care unit. So what did we observe? First of all, we had high rates of spike protein expression in the gut of post-COVID patients. Here you have a nice figure where you see the S protein in a representative patient, and compared to the negative group, we have much more expression of the S protein. Then we also did an immunophenotyping of the gut tissue, and just an overview. So we have a higher T cell frequencies in PCS patients compared to healthy persons. Lower B cell frequencies in post-COVID patients. And especially if you look at the memory cells, we have more central memory cells in the gut compared to in post-COVID patients compared to healthy controls. Interestingly, also we have more plasmacytoid dendritic cells in patients with post-COVID syndrome in gut, and also more mast cells. Moreover, we took the supernatants of the gut and did some cytokine and chemokine analysis. And what we observed is in the supernatants of the guts of the patients with post-COVID syndrome, we had more MMP9, the matrix metalloproteinase 9, in the supernatant of the patients with post-COVID syndrome. So we don't really exactly know what it means, but there are differences which are really significant. So the key findings we have here is that we have a persistent detection of the spike protein in the gut of patients with post-COVID syndrome. We have definitely immune alterations in the terminal ileum with an increase of T cell frequencies and decrease of B cell frequencies, especially central memory cells and plasmacytoid dendritic cells are increased in the gut of patients with post-COVID syndrome. The elevated levels of MMP9 might indicate an ongoing inflammation, remodeling. We are not really sure. Maybe you have some ideas. And so maybe the gut could be a persistent viral reservoir and driver of immune dysregulation. And I think we should also look more for the gut and not only the peripheral blood, because the gut is the main target of the immune system. Happy to take questions.
Thanks very much, Clara. And we have again time for some questions. Christine is already coming up. Susanne is also coming up. Decide who wants to start.
Question is the expression of the spike in the gut that you see, is that spatially correlated with an accumulation of immune cells? And if you look into individual patients, does the amount of spike correlate with these increased immune cells, T cells, and dendritic cells?
Yeah, this is an important question. So we couldn't really correlate the expression of the S protein with an accumulation of different cells, although we couldn't do that. But of course, it's kind of difficult also because the S protein was done with immunohistochemistry, and the others were with flow cytometry. So it's kind of difficult because maybe the slides are not really representative for this patient. So it's really a big limitation, I have to say. But still, it's there, and so you can really see that the patient with symptoms, they have more detectable S protein in the gut.
So similar to Susanne's question, not surprisingly, did you have a chance to look at the function, to do an IGRA or something like that, an indirect test, whether some of those T cells that you nicely, it's impressive that you have these samples, whether some of the T cells might be specific for a spike?
Yeah, we tried, and unfortunately it's really difficult because we don't have a lot of cells from the gut. So this is also a big limitation. So we tried, but we failed, I have to say. We failed, yes.
Very quick question, Clara. Did you try and did you manage to isolate infectious virus from your biopsies?
So we started with that, but we didn't detect anything, nothing.
Because it could be defective stuff that's still expressing.
Yeah, no, but we didn't detect anything.
All right, I think time's coming up. I think we should continue. I was told I should make sure to stay in time. Thank you very much, Clara. One more time. Did my job. And with this, no break, we hand over to Klaus-Michael Debatin for the pediatric session.
Yeah, thank you. Thank you all for really having an exciting session today.